Thank you so much, Dr. Amara. Hi, everybody. I know I am the only thing standing between you and lunch, so I'll try to talk as quickly as possible. I am a New Yorker, so I do talk very quickly, so just give me a timeout if I'm going too fast for any of you. I did talk last year just about thinking and memory in Parkinson's and how it's similar and different from dementia with Lewy bodies. There's a lot of confusion about the overlap and differences between those conditions, not only among the community, but also among health providers. And so I'm going to talk about a related but slightly different manifestation of Parkinson's disease today with psychosis. And psychosis is a scary word. It's a word that's used incorrectly a lot of times. But the definition of psychosis is the presence of hallucinations or delusions. And we're going to talk about what those things are, that there's a broad spectrum of how those things can manifest in people. And the main take-home message from this talk today is that if these things are happening to you or the person you love, to bring it up to your healthcare provider so that we could treat it appropriately, and to destigmatize these things and make sure we are not judgmental or fearing things that we can definitely take care of for you. So I always start off this talk with this piece of art. This is called Romeo and Juliet by a Mexican artist, Octavio Ocampo. And as you look at this picture, the first thing you kind of see is, okay, some trees, a kind of bucolic setting here, a nice picnic set out at front. But the longer you look at it, the more you see. And you see the woman looking over her shoulder in between the trees in there first. And then if you look even closer, you see two men's faces looking over her face. And then you look down at that picnic blanket and you go, ooh, that looks a little creepy down there too. So this is a visual illusion. This is normal. This is what our brain does. Our brain tries to make sense of patterns and make meaning out of those patterns. And this is a normal human phenomenon, especially seeing faces. Human beings are programmed to see faces from the time we're born. If any of you remember having newborns around where babies will attend right out of the womb to things that look like faces, human. In terms of when this becomes abnormal or a problem, it's all a matter of degree. This is normal. So we're going to talk about how psychosis can be very common along a broad spectrum of changes that can be happening. The severity can vary widely, and that it's so important to share this with the people who love you, as well as with your healthcare providers, so that we can treat it, plan better for the future, as well as decrease that stigma around it. So psychosis is just a change in how the brain processes information coming in, whether that's visual information, auditory information, tactile information. Reality is just what we all collectively decide is real. Who's to say what's real or not? Does everybody agree with you? Or does your perception of reality differ from everybody else around you? That's psychosis. Usually manifesting as hallucinations or delusions. But the underlying cause of psychosis can vary widely. Now, I will always say psychiatry and neurology are just two sides of the same coin. Just depends on how you were trained and what conditions you were trained to take care of and that you feel comfortable with. But I think in the near future, psychiatry is just going to become neurology. It's all your brain. There's no difference between your brain and your mind. It's all the same. But in terms of how we currently classify these conditions, what's neurological versus what's psychiatric versus what's medical otherwise, here down. There can be different causes of these symptoms, some of which are very easily treatable infections, medication side effects. But some of them we have to be a little bit more thoughtful and creative about managing. So in people with Parkinson's, up to 60% of people will experience some degree of psychosis. It's a high number, but it can be very varied in how much it bothers that person, how frequently it's happening, or if it's unsafe or distressing at all. Importantly, a lot of the medications that we use to treat the motor symptoms of Parkinson's disease, primarily those dopamine therapies, they can also cause hallucinations or delusions and or make them worse. So sometimes we're kind of stuck between a rock and a hard place, trying to treat how your body's moving and treat your thinking and memory and behavioral changes at the same time. Another important point, though, even people on no dopamine medicines for their Parkinson's can still have psychosis. How does dementia with Lewy bodies play into this discussion? There is a misconception that if somebody is hallucinating, especially seeing people or animals that aren't really there, that means they must have dementia with Lewy bodies and not Parkinson's. That is incorrect. Psychosis happens in both conditions. Just because somebody starts experiencing hallucinations at some point in their disease course does not change their diagnosis. How we differentiate Parkinson's disease from dementia with Lewy bodies is fully dependent on what comes first, changes with how your body is moving, or changes with your thinking and memory, what brought you to the doctor in the first place, and how bothersome and distressing those symptoms relatively are to each other. That's the only difference. All of the other features completely overlap between these two disorders. And really, Parkinson's disease and dementia with Lewy bodies are more on a spectrum together than two completely separate categories. And this kind of breakdown graphically can help understand how we use these terms. I think I shared this slide last year too, but this is the one I get asked most frequently to share with people, because you see Lewy, L-E-W-Y, he was an Austrian neuropathologist who first saw these Lewy bodies in brain slices after people had passed away with Parkinson's. They're these little red bubbles you see inside of the neurons. So Lewy bodies are present in all these diseases. It just depends how many of them are there and where are they in the brain. Of the Lewy body diseases, the two main groups are Parkinson's disease and the Lewy body dementias, plural. Parkinson's disease dementia, that comes from initially Parkinson's disease with primarily motor symptoms first and most prominent and bothersome. That later in the course, at least a year later, the person develops dementia. Why 1 year? A bunch of nerds sitting in a room together said, yeah, a year sounds good to separate them out. Very arbitrary. Dementia with Lewy bodies starts with thinking and memory trouble first. The Parkinsonism, slowness, stiffness, shakiness, comes either later on or at the same time as the thinking and memory trouble. The Parkinsonism is usually more subtle in people with DLB. They might not have much of a resting tremor. They might have more of an action and a postural tremor, or maybe just a little bit in their chin. And they're not coming to the doctor because they're noticing trouble moving. They're coming to the doctor because they're worried about their thinking and memory, or more often than not, they're dragged in by their loved ones who are worried about their thinking and memory. So to diagnose dementia with Lewy bodies as opposed to Parkinson's, there must be cognitive impairment that's significant enough to affect the person's level of daily function. That's the definition of dementia. This is a change from your baseline, not from anybody else's baseline, a decline from your baseline that is now affecting your day-to-day life. Starting with complex things like paying your bills, managing your medications, driving, shopping, cooking, but could progress to needing help with more basic things like getting dressed, bathing, or grooming. In addition to dementia, there must be one or two of these four core features. And these were updated back in 2017. They will probably be updated again in the near future. But there should be either Parkinsonism, slowness, stiffness, and shakiness, which is more subtle in people with DLB than in people with PD. but up to 85% of people will have it. And typically what they have is the bradykinesia, when we look at how fluid and quickly you're moving, when we make you do all those little dance moves in the clinic. The visual hallucinations that we're going to spend the rest of the talk talking about, which are usually well-formed, complex figures, people and animals. REM sleep behavior disorder, and significant fluctuations in their cognition, ups and downs in their level of alertness, awareness, and attention that can be confused for seizures, can be confused for syncopal or passing out events. But if you have two of these core features in the setting of dementia, you can say this is probable dementia with Lewy bodies. If you only have one of them, there's some additional tests you can do, things like the DAT scans that we also use to separate Parkinson's disease from other forms of tremor or other forms of Parkinsonism. But importantly, all four of these core clinical features of dementia with Lewy bodies all happen in people with Parkinson's too. None of these are specific for DLB. The only thing that separates them, what came first, what is more bothersome. So, hallucinations. Hallucinations are sensing something in your environment or in your body when there's nothing actually there. Again, what determines what is actually there? What does everybody else agree on? That is reality. But you can see, hear, feel, smell, taste things that aren't actually there. The most common type of hallucination that we hear in people living with Parkinson's disease are called presence or passage hallucinations. Now, again, these things are all normal. This happens to me all the time. I'll be standing somewhere and catch something out of the corner of my eye, right? Ooh, is that something just walked by over there? It's also part of my anxiety disorder, but that is normal. It is within the realm of normal to have a heightened sense of, am I safe? Anybody in this room right now had ancestors that had a good fight or flight system, right? Your ancestors survived to reproduce and make you here today. So all of us have that fight or flight system ready and primed. We just don't need it as much anymore. Presence is feeling like maybe there's somebody standing behind you or there's somebody else in the house. We sometimes call that a phantom boarder. Not that you see or hear that person necessarily, you just feel them. Now, what are ghost stories, right? How many people say, oh no, I feel a presence in this room, right? Especially around this time of year. Normal human phenomena. It's just more common if you're living with Parkinson's. And passage is that kind of corner of the eye phenomenon. You think you saw, a little mouse scurry across the floor or, something fly by the corner of your eye and you look and there's nothing there. The formed hallucinations, though, as opposed to the presence or passage, are usually figures. And they're usually very complex. Like you see the whole person's face, how they're dressed, their facial expressions. Sometimes it's somebody you recognize, sometimes it's a stranger. But the most common things are children and animals. These are not always distressing or bothersome for people. I always share one of my favorite patients. He recently passed away, but when I first met him 6 or 7 years ago, his daughter, who brought him in for the appointment, and he ended up having dementia with Lewy bodies, but she said, tell her, Dad. And he goes, I'm not telling her. She goes, Dad, tell her. What's going on? Is there something you're worried or scared about? And he's like, I don't want to tell you. The daughter's like, well, he's seeing people. Right? And then he looked kind of standoffish and upset and nervous about it. And I was like, it's okay. These are things that happen. Our brains do these things. Do you want to share more about it? Would it make you more comfortable if your daughter stepped out? No. I just don't want you to take him away from me. That's what he said. And I said, no, if it doesn't bother you, it doesn't bother me, but I'm kind of interested now. I want to know what it is. He was seeing topless belly dancers emerge from his couch. And he loved it. Again, doesn't bother you. It does not bother me. We do not have to treat this. I also have a lot of people who see puppies or children visiting, right? Again, all relative in terms of, is this scary or distressing to you? Are you acting on it unsafely? If the answer to those questions is no, it is what it is. Enjoy it. Back to those visual illusions. So a hallucination is where your brain makes something out of nothing. There's nothing there, and the brain's filling in some gaps. As opposed to illusions, which there is a stimulus there, but your brain misinterprets it. So when you look at this figure here, how many people see a duck? Raise your hand. How many people see a rabbit? Now, who saw the duck and now sees the rabbit? Right? So again, our brain just does this. This is part of a survival mechanism of, is this thing threatening to me? Is it going to kill me or eat me? I got to think about how could this possibly be formed here? Is it dangerous? All of us see patterns in randomness, especially faces. So this is called pareidolia, seeing order in randomness, especially faces in inanimate objects. So none of these things were created to have faces on them, but you see faces in all these, right? This is normal. We all do this. It just happens more if your brain also has Parkinson's. We can test for pareidolia in the clinic. This is called the noise pareidolia test. It was developed in Japan. We show 40 of these ink blot cards. Now, we're not using ink blots like Sigmund Freud did to see, what your deep-seated traumas are. No, I just want to know, do you see a face in here or no? Right. So some of these cards have faces and some do not. And when we go through 40 of these cards with people living with Parkinson's or with dementia with Lewy bodies, they will see more faces on the non-face cards. If they see 3 or more faces on non-face cards, then it is very sensitive and specific that they have a Parkinsonian disorder. So I very commonly use this test because people come to see me in the memory clinic, right? They just say, my memory's bad. Or more often than not, their family's like, their memory's bad. And I might be picking up some subtle Parkinsonism. It might be a little slow or stiff or have less facial expression, but they didn't come to see me for that. And I'm trying to separate out, is this something like Alzheimer's or is this a Parkinsonian disorder? I'm number one, going to ask them if they're acting out their dreams because people with Alzheimer's don't do that. Only people with Parkinson's and Lewy body do that. But I'm going to show them these cards because people with Alzheimer's will not see faces where there are no faces, but people with Lewy body will. Shifting gears a little bit, delusions. Another word that's used incorrectly all the time, so-and-so is delusional. A delusion is a false, fixed belief that does not fit, again, with the collective sense of reality when there is evidence to the contrary. These are usually paranoid or persecutory. Somebody's stealing from me, my partner's cheating on me, people are surveying me. That's a very common one in people with Parkinson's dementia with Lewy bodies, is they think people are spying on them, or people are kind of driving by the house to see what they're doing, or the airplanes flying over their house or watching them. I've had a couple of people tell me that the sprinklers are spying on them. So those are delusions. They're not seeing or feeling or hearing things that aren't really there, but they're believing things that are false. It can be very difficult to convince the person it's not true because their brain will not accept that information. And typically I find people much more distressed, disabled, and bothered by delusions, both the person living with the delusions as well as their loved ones, than I do the hallucinations. A type of delusion that's very common, and this can happen in any form of dementia, but more in people with Lewy body and Parkinson's dementia, are delusional misidentification syndromes, usually focused around a theme of duplication. I know you look exactly like my wife. You're not my wife. I want my real wife back. I know this looks exactly like our house. This isn't our house. Take me to our real house. Usually happens more in the evenings when the ambient lighting and other stimulation is decreasing and the brain has more opportunity to fill in the gaps incorrectly. This can be very distressing for people and difficult to treat. But importantly, bringing this up to your medical providers so that they can try to treat it for you. Because this can be unsafe, right? If somebody's calling the cops, running out of the house in the middle of the night because they think you're an imposter that looks exactly like their wife, but you're not their wife. So when we talk about psychosis and the underlying causes, as I already alluded to, it can be due to primary structural brain changes, the hardware in your brain, the software network changes in your brain that we consider more psychiatric, but it can also be medical and iatrogenic, meaning we did it to you as your doctors, not on purpose, but because a lot of the medicines that we use to treat Parkinson's itself, as well as treating related conditions like pain or muscle stiffness, or if you just get a urinary tract infection or an upper respiratory infection and you're put on some other medications by your other medical providers, it can induce psychosis. The common Parkinson's related medications that we need to be careful with, especially if somebody also has dementia, especially if they start experiencing hallucinations and or delusions. Amantadine, Artane or trihexyphenidyl, and then those dopamine agonists, things like Requip or ropinirole or Mirapex or pramipexole, those can make these things worse. And the first thing we want to do before adding more medicines to the mix is get rid of any that might be making it worse. But oftentimes we're stuck, again, that rock and hard place of managing your movement symptoms without worsening thinking and memory and behavior and trying to find the best balance for any one person. When we're trying to treat hallucinations and delusions in people with Parkinson's or with Lewy body, again, we don't got to do anything unless it's bothering you. I never treated my person with his naked belly dancers. It's never a problem. But if it's bothersome or unsafe, we got to do something about it. The easiest things to do are setting up the environment correctly. Take away those opportunities for the brain to misinterpret things. I was just on a family conference call on Tuesday with the family of a patient of mine who's living in a memory care unit, and they're worried that his behaviors are worsening. Do we have to give him antipsychotic medications? And my question to them was, well, what's going on? Tell me, give me some examples. Well, there's a mirror in his room, and every time he sees the mirror, he thinks it's a portal to another dimension, and he gets upset and scared, and he wants it gone. What's the answer? Get rid of the mirror, right? Done. So those types of things that are very simple and easy to do, very safe. They're not going to have any side effects from getting rid of the guy's mirror. But keeping the rooms well lit and uncluttered. Another example, a woman who every time she saw the coat rack tree in the foyer, she thought it was a man standing in the corner of the foyer. Get rid of the coat rack. Busy, patterned upholstery, like the couch with all the flowers on it, right? You know, that couch usually has plastic over it. Put a slip cover on it, right? So anything we can do to simplify, declutter. Sometimes telling people to focus on or try to interact with the hallucination, this works best with like figures. Sometimes people have some insight, like they know, I know this person can't actually be in the kitchen here with me. There's nobody else here, but I'm seeing this person. Is it real? Asking somebody you trust and love that's in the room with you. Are you seeing this person? No, I'm not, but I know you are. Like, how can I help, right? non-judgmental, meeting the person where they're at, but sometimes talking to the figure and seeing if they respond, because usually they won't talk back, or changing your perspective. The easiest thing to do is to have one of those really bright flashlights and to shine it on the person. And by changing the lighting on the hallucination, it often goes away, where the brain goes, oh, there's actually not anything there. Sorry. Boop, gone. And then after adjusting the environment, anything we can do that's simple, low-hanging fruit, then saying which medicines on this list can we get rid of? Acknowledging that this is very real to that person experiencing it. They will often not be reassured if they've lost insight to the fact that this is not real. By you insisting it's not real will often just be more upsetting to the person, especially if they have more advanced thinking and memory trouble. But being calm, non-judgmental, accepting their reality, and then distracting them. The best tip for de-escalating a situation, can you help me with this? Because people living with cognitive impairment very much want to be involved and contribute to their households. And they often know something's wrong. They can't quite put their finger on it, but their normal routines and activities around the household have been disrupted. And all that energy has nowhere to go. And so often that manifests as behavioral symptoms, whether it's agitation or aggression, pacing, wandering, hallucinations and delusions. So to de-escalate and to try to get somebody out of that vicious loop of their brain getting overstimulated in the wrong ways, having a set group of tasks to allow that person to get that energy out and to contribute to the household. And sometimes it takes some trial and error to find the right tasks for that person. It should be something aligned with what they did throughout their lives. So if it's somebody that's always hated folding laundry, don't make them match the socks, right? But if they liked matching socks and that was kind of repetitive and soothing to them, have a big laundry basket, go to the dollar store, get a bunch of different sizes and colors of socks, and let them match the socks. And that can be a very easy off-ramp from these things spiraling. So if the symptoms of psychosis are bothersome and distressing or unsafe, what do we do about it? We need to be extremely careful because the vast majority of antipsychotic medications work by blocking dopamine. Do you want to block dopamine in somebody with not enough dopamine to start with? No. So these medications listed up here are absolute no-goes for the vast majority of people living with Parkinson's. These medications can not only cause severe worsening of the Parkinsonism, basically just turning people completely off, but they can cause very severe thinking and memory impairments, sometimes paradoxically making their psychosis worse. Never get these. Unless I say it's okay. Every once in a while, we need to use one of these because the other ones aren't cutting it and the person's very unsafe. But basically, never receive any of these. And importantly, if you ever go into the hospital because you're getting your hip done or you had an infection, and if you get confused in the hospital, a delirium, which is a sudden acute onset confusion, usually with hallucinations and delusions, what's the first thing the doctors give you overnight when you're confused and hallucinating? It's one of these. So very commonly here, we will put in these medications as allergies for anybody living with Parkinson's, because if you try to order a medicine that's listed as an allergy for any person in the system, 75 alarm bells come off and like the SWAT team drops from the ceiling. But if you just try to tell people, oh, no, I can't get those, I have Parkinson's, they might not hear that. So if we need to treat psychosis in Parkinson's, we've tried adjusting the environment, we've tried reassuring and distracting, we've tried getting off as many medicines as we can, and the person's still very bothered, distressed, or unsafe. There are 3 medicines that are safer. They're not safe per se, they're safer. Because every antipsychotic has a black box warning saying if an older adult, especially an older adult with dementia, receives these drugs, there is a higher risk of sudden death. Not a lot outweighs sudden death as a risk. It must be a pretty significant benefit to outweigh that. But if somebody is so unsafe or so distressed by these things, oftentimes we have to do what we have to do, right? So quetiapine, or Seroquel is the brand name, is the one that we will most commonly use for Parkinson's psychosis. At doses less than 300 to 400 milligrams a day, it really doesn't block dopamine much. It works more on serotonin, another chemical in the brain. And the psychiatrists laugh at us. Like, we'll start 12.5 milligrams, and the psychiatrists start 400 milligrams for things like schizophrenia or bipolar disorder. But we start teeny tiny baby doses, usually just at bedtime, because it can cause sleepiness. Clozapine, or Clozaril, also works very well and is safer for people with Parkinson's. The problem is it has a 0.4% risk of shutting down your bone marrow, which is also a huge risk. And so we have to check your blood counts every week for several months, and then every month forever. But it works, but it's hard to use. And then pimavanserin, or Nuplazid, was approved back in 2016. We were all very excited about it in the Parkinson's disease world because it doesn't work on dopamine at all. It only works on serotonin. The problem is it's very expensive and it can be hard to get. And just kind of anecdotally over the past few years, it hasn't worked as well as I was hoping it would. So I'll usually still start with quetiapine. If that's not enough, I'll add the pimavanserin. If that works better, I'll take off the quetiapine. And then if those aren't working, we have to think about the clozapine. Importantly, the thinking and memory pills, donepezil or Aricept, or rivastigmine or Exelon. Rivastigmine is FDA approved for Parkinson's disease dementia. Donepezil's not, but it's once a day, and rivastigmine's twice a day, and it's cheaper. So I'll usually still stick with donepezil. But those 2 thinking and memory boosters can also treat hallucinations and delusions themselves. So I will always start there. If somebody's not on one of those, I'll start that first rather than jumping to an antipsychotic. We've already kind of touched on this in terms of what can happen in the hospital to somebody living with Parkinson's disease, and delirium, which is common in any of us in an unfamiliar environment if we're sick and getting medications and being kept up all night by somebody coming in and checking our blood pressure, and IV beeping. But delirium can have hallucinations and delusions with it. It will be a sudden change. The delusions and hallucinations that happen with Parkinson's are usually gradual, insidious in onset. If anybody ever calls and it's a sudden change, somebody's much more confused, all of a sudden they're hallucinating, the next question is, what else is going on? Do they have an infection? Were there any medication changes? Are they sleeping okay? Are they constipated? Being constipated can make you delirious. Drink your water. Exercise. I always give a plug for the Aware and Care Kit from the Parkinson's Foundation. It's free. You just have to pay shipping. And it has a description of what delirium can look like in somebody with Parkinson's, as well as a list of those medications you cannot receive. And it has a little magnet that you can put up on that whiteboard in the hospital room that says basically, I have Parkinson's. I'm special. Stop. Oh, I see it. Yep. Show everybody. Can you show everybody the Aware Care? It's cute. It's like a little lunchbox. You can bring all your meds in. But it's just another little flag to your care team in the hospital, many of whom are not super familiar with Parkinson's, that, hey, wait a minute, you got to treat me a little differently. So overall, hallucinations and delusions are common, but there is a broad range of how they can manifest, and they can be very subtle, mild, non-distressing, or even pleasurable for some people. The most important thing for treating is getting rid of other things that can be causing it or making it worse, and being very careful if you do need to use a medication to treat it about how you choose that medicine and the relative risks and benefits. And that a sudden onset out of nowhere of hallucinations and delusions in somebody living with Parkinson's should trigger a search for another cause, not just blaming it on the Parkinson's itself. Thank you so much for your attention. And